I'm Josh Young. I'm here with Raja Datta. We're going to be talking about CME in diabetic patients. And what I want to know is this. In post-cataract CME in diabetics, is the CME etiology entirely inflammatory, or is there some non-inflammatory vasculopathic component to it?
If it's a diabetic macular edema, or diabetic CME as you say, what is the basic pathophysiology of diabetic CME? It is vasculopathic. And how does this happen? Because due to the end products of glycosylation that takes place in diabetes mellitus, we have these end products acting on the retinal vasculature or retinal microvasculature, as we say. And this leads to a thickening of the basement membrane, loss of pericytes, and this causes a loosening up of the endothelial intercellular junctions, which leads to increased permeability of the blood vessels. This therefore opens up the blood retinal barrier. So it is known as open BRB condition, and this is also known as extracellular edema. So that's the primary cause in diabetes mellitus. Another cause that is prevalent in diabetes mellitus, due to this accumulation of fluid in the retinal tissue, what happens is that retinal tissue undergoes hypoxia. This hypoxia in turn releases certain cytokines known as VEGF, or vascular endothelial growth factors, as you all know. And this accumulates in the vitreous cavity. This in turn again releases certain substances which goes in, affects the vascular wall, and again makes it permeable, leading to leakage of plasma and its components. And the third factor that is common, both that is in non-diabetic macular edema as well as macular diabetic edema, is the inflammatory cause, as you have stated. And this inflammatory cause is again due to the release of arachidonic acid by phospholipase in the cells. This arachidonic acid is acted upon by the cyclooxygenase present in the cells, leading to the release of prostaglandins. And these prostaglandins, they act on the vascular walls, vasodilating them, loosening the intracellular junctions, and also it prevents taking up of the subretinal fluid by the RPE, or the retinal pigment epithelium.
So this is an important clinical and not just an academic point, because the problem is that clinically, we have a patient who prior to cataract surgery had a macula that was compact, and after cataract surgery has a macula that is swollen. And it's important to make the distinction as to whether the etiology is vasculopathic, is a blood retinal barrier breakdown, as we say, is a VEGF problem. As you know, when VEGF was described first, it was described both as VEGF and as vascular permeability factor, because there's this profound effect on permeability and on the inflammatory component. And obviously, any one of these etiologies can aggravate the other two. The problem is that these get treated differently. So when we have a patient, a diabetic patient after cataract surgery with edema, how do we treat it? Let me back up one step and ask you what your study was, how you set it up, and what your findings were.
Yeah, my study basically was a case cohort study on 300 patients who underwent surgery at my facility in the last 1 year. And what I basically did is, the first we divided into this cohort into sub-cohorts. The first sub-cohort was division into males and females, number of males, number of females. Then dividing these patients into two more cohorts, that is diabetics and non-diabetics. Then we observed for how many patients out of these had foveal thickness, increased foveal thickness, on the 10th postoperative day by OCT. And then we found out and recorded these numbers also as to how many had increased foveal thickness and how many did not have. So out of these, we found out how many patients were diabetic having an increased foveal thickness, that is diabetic macular edema, and how many patients did not have diabetic macular edema or macular edema at all. And then we also found out how many females and males, female diabetics, how many of them had macular edema, and male diabetics, how many of them had macular edema. And basically, to conclude, we found that not many, like out of this 300 patients that we had, 28 developed post-operative macular edema, out of which 22 were diabetics. Okay. And out of these 22 diabetics, 14 were females. Now that was a clinically significant finding we had. And mostly on the 10th post-op day, most of the patients were having a foveal thickness in between 200 to 300 microns. So that means it was a mild diabetic macular edema.
In terms of incorporating these findings into your practice, into my practice, into all of our practices, what is your approach clinically with these patients after cataract surgery, a diabetic patient with edema of the macula? Is your first course of therapy to presumptively treat it as an inflammatory etiology, and if that fails, then to pursue it as if it's a clinically significant macular diabetic etiology, or do you do some sort of combined treatment from the get-go?
I suppose we all cataract surgeons, we put the patients on steroids from the very first day. That's a routine treatment, I suppose. So the inflammatory factor is taken care of. Now, if we have to do something, first of all, the early diagnosis part of it. So as I said, even on the 10th day we can diagnose if we take the foveal thickness in the OCT. We can diagnose it because there's this initial part of it shows a little retinal thickening. It will not show you a cystoid macular edema on the 10th day, which goes on to develop at a later stage, maybe after a month, 2 months, 3 months. But most of the time we have this small amount of retinal thickness, increased retinal thickness, and that should be the alarm that sounds in our mind that yes, this patient needs observation and start treatment now. So what we can do is we can, on top of the steroids that we use, we can also introduce some NSAIDs, topical NSAIDs, say nepafenib or something of that sort, and observe the patient. Say another week later, we can go for another OCT and find out if it has increased. And we find out how much increase is taking place, because we don't have to go in for a very commando type of a treatment in these cases, because most of them will go on to resolution on its own after a few weeks maybe. But the first and the foremost thing I would like to ask all the physicians, and of course to tell the patients, is to go for a strict control of diabetes and monitor the blood sugar regularly. And medication, I think, is the next step. And if some patients go on to CSME, then we have to consider going for intravitreal injections of steroids or anti-VEGF.
Roger, great study. I mean, certainly very, very relevant. Thank you very much for spending the time with us today.
Yeah, thank you very much. I'm also happy that you called me here. Thanks a lot.